And coming to you live from Mount Sinai.
Well, that's a nice case.
That's
That's
going to be a
really
good case.
nice.
So we are
Hello,
all
hello,
ready
good
here?
morning.
We
Hi,
did get.
Dr. Kinney, we
Yes.
see you.
All
Good
right, so
morning.
everybody say to the camera. Yeah. Okay. Good.
So we can show the slides for
Yeah.
case number 2, where we have a 82-year-old male who presented with the dyspnea, NYSA class 3. And with regards to his past medical history,
Tell
he
them
has
next slide.
hypertension, hyperlipidemia, as well as CVA with no residual deficit. Again, another patient with the prior PCIs and good medical therapy at this time. So if you see this EKG with the left bundle and PR of 160 milliseconds and QRS of 166 milliseconds. EF is near normal with the severe aortic stenosis with a peak gradient, if you see there, about 37 to 40 millimeters of
Good.
Yeah.
mercury.
Good. Good. Yeah. Yeah. So basically, this patient has a calcium everywhere. Severe peripheral vascular disease, calcific, severe coronary artery disease,
Take it
which
down.
require rotational atherectomy. So this is a challenge for us, and that's what we have started working on this case a few minutes ago, and try to see what can we do with such a high calcium in the peripheral artery. Next slide. Stem.
Yes. Uh, Basically, normal ejection fraction, severe AS, minimal AI. So I can show real life on
Good.
PE.
Okay. Next slide. Good. Jason,
Good.
talk about the CTA.
Good morning, everybody. So to go take you through the CTA, this patient, severe calcific disease, you can see the aortic annulus there gives a perimeter of about 75.8 millimeters. Area is 440.9. Angle is fairly benign for us. Importantly, in terms of pre and post dilation, minimum across the annulus is 22.6, maximum 25, mean is 24. And no big nodules of calcification in this annulus, which is important because it allows us to use the Evolut R system, which saves us 2 French sizes, which you see is very important as we get to the peripheral axis in a moment. Next. Next slide, please. Good. So here you can see the SOV. SOV itself is fairly generous. So particularly the left coronary cusp across is about 34 millimeters, and the average sinus size is around 31. But importantly, I direct you to that picture of the sinus at around 4 to 5 p.m. You can see there the left main is entering the sinus, and there's a lot of leaflet that we can still see opacified on the CT at the level of the left main. Importantly, that left coronary cusp leaflet, you can see it right at the bottom of the picture there, is about 16 millimeters long, or 15.8 you can see there. And the left main height itself is less than 10 millimeters. So the relationship between that long left coronary cusp, low left main is unfavorable, although definitely the SOV is generous in this patient. Right coronary artery, you can see there is quite high at 15 millimeters. Other parameters are quite within range for what we're doing here. Next slide, please.
So therefore, Jason, you are very much concerned
Yes.
that although the sinus is quite big, but because of the leaflet is so big,
Exactly.
That it may obstruct the left main.
Exactly. Go -1 here. That's a critical point. So normally when the left main is less than about 12 millimeters in height, go -1 slide, please. When the left main is less than about 12.
Yeah, let's go
no,
back
that's
to the
positive.
left main.
-2 slides now.
Slides. 2 slides
And
back.
-2 slides.
Yeah.
This slide here.
Yeah.
So exactly, Dr. Sharma, when the leaflet, the left leaflet is very long and the left main is very low, so particularly when there's more than about 4 to 5 millimeters greater length of the left coronary leaflet versus the height of the left main, we get concerned. And just that picture there of the sinuses where you can see the left main entering at about 4 p.m. versus the length of that leaflet cusp is of concern. Just that very appearance of that SOV there is concerning.
Yeah. So basically, as you know, that 2 things which have been in the literature is the left main height less than 10 and sinus
Yes.
valsalva of less than 30.
Yes.
So that combination is high. In this case, our good advantage is sinus valsalva is large, but it is counteracted by the leaflet length. And that is
Exactly.
where the whole issue is. Yeah.
Exactly.
Keep going.
I'm
We'll
sure-
have a lot of discussion later.
Exactly. Next slide, please now. So here you can see the femoral axis. So the left, just to show you that on the left side, it's a prohibitive the aortoiliac bifurcation. So we've gone on the right side. You can see the right over the common femoral head actually has no calcium. So this is a percutaneous case. We've already got two pre-closes in the right common femoral. But in the common iliac artery, you can see the severe calcific disease there. And you can see on those images, the minimum diameter through that calcified area is down to around 3 millimeters. Thankfully, in our favor, the calcium is not totally circumferential, but this is definitely severe calcific vascular disease requiring extra steps to get up, as we're going to show you. Next slide. Here's just a laid out view. You can see there what we're dealing with. And right up at the aortoiliac bifurcation on the right side, as I said, it's around 3 millimeters in diameter. Next slide. Next slide. So here, what our strategy is going to be to protect the left main, we're going to go with an Evolut R system. So we're actually going to put a tail in from the right radial, but you can see here the arch anatomy is favorable. And as Gilbert said in the last case, we do this routinely to check for cerebral protection. But in this case, we need the right radial for the pigtail, which we'll show you in a moment. Next slide.
And this is the case where I showed the preference of the Evolut versus the Sapien, that once your vessel size is 5 millimeter or so, I think the only device which will go is your Evolut, and that too is R,
Exactly.
not Pro.
Exactly.
Next.
Exactly. So to summarize the case, our measurements here come out for a 29 millimeter Evolut valve. We've gone with the R, not the Pro, because this will save us 2 French sizes in getting up. So it's just a 14 French inline system. 14 French, mind you, is still a diameter of 6 millimeters. And I said we've got diameters of around 3 millimeters in that calcified common iliac. So we've got some work to do to get up there for you. Next slide.
So this puts it together. Now tell us what you have done so far.
Sure. So just show us the cine images, please. Show us the images. Good. So just to show you, this is a tempo lead. This is an active fixation system, and the panel may care to comment. I'm not going to dwell on this because they've got a lot of additional work to do, but this is an active fixation pacemaker lead that enables early patient mobilization if we have trouble. This patient has a baseline left bundle, so hopefully they won't require a pacemaker. This is just showing you here, this is the left side, this is the minor access side, but severe calcific disease. Here we're in the left side. We've put a long 6 French sheath up. This is the right side where we actually did percutaneous access. You can see beautifully here the extent of disease. We've stuck up high here. Oh, this is our root shot, sorry. All getting prepared. This is some coronary shots because we're going to be protecting the left main. So the left main is quite short here. We'll be parking a stent into the LAD. I think this is a 3.5/18 stent will work well for our purposes. You can see here exactly where I've entered the needle and threaded a wire up. We're above a level of the fovea above all that calcific disease. Here we're in. This is an 11 French sheath, 11 French. We need to get 14 up, and you see we're not even able to get this into the beginning of this calcific disease here. This is a DSA shot from above showing you all this hazy sort of pacification there in the common iliac. That's the severe calcific disease we've got to get up for you. So what we're going to be using today is this shockwave system. Shockwave is an adaptation of lithotripsy. Basically, you all know lithotripsy is for blasting kidney stones. This is ultrasound technology. We now have these shockwave balloons, which is ultrasound technology, which can similarly fracture and shatter calcified disease. So it comes on a balloon system in a range of sizes, ranging from around, I think, 4.5 up to around 8. And we're able to inflate this shockwave balloon and do basically focal lithotripsy to the lesions. We decided to do one run of this because we are allowed to do 5 blasts of lithotripsy each of 30 seconds, which takes multiple minutes. So we decided to do this before time. You can see here the indentation of that balloon. This is a 7.0 balloon, quite indented, but starting to open up a little with this lithotripsy. We haven't finished though. We've actually taken a second fresh one of these, and we're going to show you this live. This is us checking the valve, and here we are. We haven't actually tried to pass the 14 French up.
All
so
right.
we're going to go live.
So
And
you
basically
perform
because of this,
shockwave.
vascular
You
act-
perform shockwave in both the iliac and the right femoral. So now we're going to watch how that worked.
Not down into the right femoral,
yet.
just in the common iliac.
Common iliac.
Common
So
iliac.
now I do
Okay,
wanna give a
let's see
shout out
what
to
you're
my-
doing.
Rox, have they also used?
Yeah. And Remy Tadros, our vascular
Yeah,
surgeon, actually, unfortunately, does not have the mic. But about 5-6% of the tower now are with the transfemoral, but they require the help of the vascular surgeon, sometimes cut down or sometimes this innovative technique,
Right.
which they are doing it now. Okay.
Let me just show you here. We're going up to 4 atmospheres, which is our inflation pressure. You can see those multiple markers. They are actually the emitter cathodes for this valve up to 4. You can see it's dilated a little since we went up the first time, but still not. There's still a little waste there at the aortoiliac. So our colleague Remy Tadros is now activating the device. You can see that in his finger, he presses, and for 30 seconds, it's pulsing. I don't know if you can hear that in
Very
the crowd,
nice,
but it's
it's
pulsing
Yeah.
now.
Dr. Colombo, you wanted to
You
make
know,
a point?
I think it's very nice because it's safe. I've been doing a lot of peripheral iliac. You can do the same with high pressure balloon, but then sometimes you get surprised. You
You
see
can
that the
dissect
blood
it.
pressure goes down to 0, and that's not pleasant.
Yeah.
And with that, you
Yeah.
don't need to protect with a V18. Generally, we protect with a
Do you
wire.
protect with a wire, or you
Yeah,
feel confident here?
Always. No, here they were going to protect, right?
No, we haven't protected
Yes.
this because I totally agree. For a routine case, we do protect.
Yeah.
We haven't protected here, not because as I thought initially this system may heat the wire up to thousands of degrees. It doesn't do that. It's actually okay to jail a wire alongside, but more if we actually happen to perforate this and we needed to do a covered stent.
Still
and we
did not
actually- we-
really fully break the calcium.
Yeah, but it looks so
It
much
looks
better
okay.
than the
It looks
first.
okay, but the calcium is not. You see the balloon marker, which
Yeah.
is.
Yeah,
Come
Which
up here.
atmosphere?
Come here.
but still we can't assess. I think we do one more proximal.
Yeah.
Can we go up with the sheet now? After
We're gonna just do one more proximal.
or we are going to do?
So
may I ask
the-
a
So, yeah,
question?
we're
How many
committed-
atmosphere is in fact
How
the
many
balloon?
atmospheres did you go up?
This is just the 4 atmospheres, which is so that's actually governed, is a great question. It's governed not by the compliance of the balloon as we
Yeah.
normally work from. That's to do with the optimal characteristics of the ultrasound for penetrating into the calcium. And the balloon is optimized for
paradoxically,
ultrasound at 4.
this system works more if it's a 360 degree or closer. The more calcium, the better it is.
Yeah.
If you have only 90 degree, it may not
It
work.
goes the other
because
way.
It expands
Right,
the other
right.
way.
It's what you just
Need
told.
a real
Yes, it's a
nice
rigid.
chunk of circumferential calcium.
Okay,
okay.
well, let's see how it worked.
Right, so we just
Most probably we'll
each
get away
inflation is
even
30
without.
seconds, which is why we're pausing here. Good. So what we're going to do is take the balloon out of the body. I've been told it's safe to show you this on my hand. So if you could get the camera to zoom up on the field here. Get the camera to zoom up on the field. I'm just going to clean the balloon off for you. Zoom up on this balloon, please.
Yeah, we see the balloon.
Can you see that? Great.
Yep.
Good. Give it 4 atmospheres. We're just going to show you what it does. So this is just with 4 atmospheres. Okay, and I'll tell you if my hand, you can see it there. These are the shocking it does. My hand it feels nothing.
Oh, you're shocking yourself.
That's the system.
Yeah,
Interesting.
no.
Thanks for that.
You want
That's a
one
very,
tomorrow?
very nice.
Dr. Sharma requires absolute
demonstration.
commitment
Thank
from
you.
his team. So.
Let's see what it did. Let's see what it did to the artery instead of your hand.
Sure. So we'll do a DSA run for you here. Good. We'll set up for a DSA here.
So what wire is that? The balloon is over an 18 wire?
Yeah, unfortunately, this system only comes up for an 014 compatible system. So we're actually on an exchange length Grand Slam.
Yeah, so because
can
you're
see it's
going to need
opened
to
up.
change
There's
that. It
no
looks much
perforation.
better.
Yeah.
This stuff works.
So
Well, you know, some
yeah, so
Well,
what
let's
we
see. Let us see if we
N
can
of
get
one.
the sheath in.
Enough works if the valve goes up.
Can you use the billing for
so what we're doing now is we're just changing out to our stiff wire. So
Yeah. Very impressive.
just
Very,
sending
very
up
nice
back to-
demonstration.
Are they using additional propofol?
Are you using
Patients,
additional propofol?
Yeah.
That's a good anesthesia question.
No. For the peripheral application.
So
For the peripheral application,
Yep.
Oh,
You just
not yet.
coated
That
with
we
propofol.
might use lubricate.
to
Yeah.
are you
lubricate.
lubricating
Yeah,
with
our
propofol?
preference is actually we usually use Rotaglide, but we may do, we probably will do that. In fact, it's a great suggestion.
And
It's
we
a
can
great
use the
idea.
Rotaglide. Rotaglide works very well.
The
for us.
Rotaglide.
Yeah.
Yeah.
Beautiful. Very, very nice
Yeah, then we're
demonstration.
gonna.
Okay, let's see
Yeah.
what is happening now.
So
we-
now
this
you
is- we're
bring
just
your
going up
stiff
with
wire.
the Amplat super stiff wire. Yep. Good. You got the sheath.
To put the sheath.
So
now
yeah.
the
So
moment
now
of
what we're gonna
truth.
do is put.
Yeah.
Yeah. So we're gonna go, as I said, we're gonna go in line with the valve. But what we're gonna do now is pass a 14 French cook sheath. Oh wait, wait.
Okay.
14 French cook sheath to see that that will go, and maybe to do a little further dilation if necessary with the sheath itself.
You want this?
Yeah.
If you
Okay.
can- if
So
you
we are
can-
going to now lubricate with the Rotaglide.
This I don't think the valve is what we.
This
Okay.
is lubricated sheet.
Yeah, a little more.
14.
And the
you
valve
also
too.
Go sheathless too.
Yeah, that's what
Did
I
you
was
hear
saying.
that?
Sheetless with.
That's what we're
What
gonna do.
about going sheathless?
No,
Exactly.
if you get the.
No, we know, but remember
what we're
you
gonna
have to
do.
make sure that it
Dilate
can go.
first, yeah.
Yeah.
This will be sheathless. This
It
is
will
a
be
14.
sheetless, yeah.
This is a 14, which is just sort of going. Our surgical colleague here, Rami Tedros, has enormous experience in this. He does a lot of TVAR and EVAR, so has great experience with getting in and out of these difficult vessels. So he's really a part of our
You
team.
see the
Oh,
front.
good,
Go with
Rami?
the dilator only alone?
You know, if
The 14,
when
he's got the
the
dilator.
advantage of having over a contralateral wire
What's that?
is that at this point you can go down with a small balloon, just
solid
a
path?
4 mm balloon, and do a bad inflation.
Solid path.
And
To
then,
allow it to come up.
yeah, even without the shock waves, I
Right.
tell you,
Yeah.
and works.
From the other
So-
side, did you hear that? And bringing in a
side.
balloon from the other side just to give you a little bit of an outlet of
So what's the
ability to
wire
deliver
you're
that.
using now?
And with a long balloon,
I
you
don't-
facilitate. You
But
facilitate.
it's possible to use a larger balloon,
With a full
shockwave
inside.
balloon, or is the maximum they use?
All excellent.
But the problem of the
All
shock
excellent
wave, they didn't break
suggestions.
the calcium because was not circumferential enough. When you see the marker pushed on the side, means that it's not really working.
Right.
Okay.
So
All excellent suggestions. We have a lot of experience. I just show the field. This is a Solopath collapsible
Wire is long
sheath.
wire, stiff wire.
This is a 19 French Solopath collapsible sheath, which we use a lot.
Okay.
This sheath is actually going to go up. You'll see this go straight up. This sheath right now has a diameter of about 8 French, straight up.
Yeah.
This is a 19 French sheath. We're going to expand it. It's collapsed now. Where's the inflator? Here's your no.
And
So we're
despite,
actually
the,
going to inflate this up now.
despite the fact that Evolut
the-
R
that-
can go sheetless, he was smart to try with the 14 before, right?
Yeah.
Otherwise, he would be
Yeah.
surprised
Oh, yeah,
with the
I
tower
can tell you. Oh, yeah. Oh, the tower would have been dislodged. No question
So,
there.
so watch what we're doing here. You'll see
Okay,
this.
so-
There's a balloon on. You see this inflating
Oh,
here.
there you go.
This is actually on the dilator inside the sheath. We're now putting this system right up to 19 French. This goes to 20 atmospheres, and we're going to sit here for a minute.
Okay.
also what
The
you could-
concern is
It's
that
a
this sheath
collapsible
isn't. It's
sheath that
collapsible,
now is getting
expandable.
expanded to 19 French. Wow.
The one risk with this is the sheath. It's not a very robust sheath. It's actually obviously can expand and contract, but it may recoil on the calcium, and we may still struggle to get the valve up inside this if the calcium constricts on this sheath. We shall see.
Let's see
One
how it
important
goes.
point you have to be careful.
Another thing
Is,
that you
Jake,
could do
we
is
have seen when
Yeah.
you do this in calcific arteries, and then when you are deflating,
Yes.
you know, we have had
Yes. So,
or that can be stuck to the
Yeah.
vessel.
so the trick here for these vessels is that this sheath is collapsible, and this Solopath comes in a non-collapsible variety. We've had problems here when we've gone with a non-collapsible variety, and it's been stuck and impossible to get out. So this sheath will collapse at the end of the procedure, and we should be able to remove everything without trouble. So we're just suturing the sheath in. Let's get, and we can pass this 14 cook inside. If the 14 cook goes inside this, we're in business.
Because that's a 19
So just
French
the-
now, is
hold
that
it.
correct? You've expanded this
Yeah.
now up to
Yes.
19 French, correct?
Yes, exactly.
And now you'll put a 14 inside
Exactly.
of that.
It's just to see that everything's going to go. Exactly.
Let's hope. Yeah, let's see what happens. So you're still keeping that
We can't go
balloon
with the valve
dilated?
inside there?
And if this goes, no,
Or
that we've taken.
it's
So
been-
just to show you
you
what we've
took it
got
out.
now,
Okay,
that's been
good.
deflated and that's out, and now we're going with a
should
14.
go.
The same 14 French. Yeah, this should go. This is the same sheath we tried to pass up just
Dilator
a couple
ahead.
of minutes ago,
Nice.
going up.
Okay, good.
Beautiful.
So we're all the way up.
Do you ever have
Okay,
a
and what about
problem
the
of the
anti-coagulation
sheath sort of
regime?
collapsing on top of this
Nothing.
or according, you know,
is-
in an accordion
Def-
effect when you're going up with a sheath like that?
Definitely.
Yeah.
Definitely. Yes, that can happen. What is the reason we took this sheath is because it's fairly straight. In tortuous vessels, this sheath will just kink off. But this is a very straight shot up these iliacs, which is very much in the favor of using this Solopath sheath.
Do you also think that the shockwave helped you deliver that expandable sheath or not? Or you could have gone
Absolutely.
directly?
100%.
Absolutely.
Okay.
No, I don't think we would have gone directly, or if we had have gone directly, and we may have got it up, it would have collapsed back. The
us
calcium would have collapsed back on this
Wire to
sheath.
cross the valve.
Okay, so now you're crossing the valve, and
I need it.
I
So-
imagine you're thinking about doing a valvuloplasty before.
Fluorosis?
Is that correct, Jason?
Absolutely. Fluoro, yes, absolutely. Fluoro? Absolutely, yeah. Especially if we're going to go
Then
inline,
we go lights down.
we didn't want to have any trouble with the inline system not being able to cross. Now that we have actually put this sheath in, collapsible sheath, it's a little less critical that we predilate, but the valve is severely calcific. So I think it's definitely appropriate that we predilate here.
Okay, we cross the valve the same with AR2 and a straight Tarumo wire.
Nice.
And let's get the
Prep the,
gradient.
prep the guide.
So you go through
prep
your
the guide.
steps again to exchange with a pigtail and then a stiff wire. Is that correct?
Yes, and now you see the gradient there. This is what I'm going to do. Go with the regular 35 wire, change to pigtail, pigtail to confida wire.
Beautiful.
Is there some regurgitation, aortic regurgitation? Because from the pattern of hemodynamics, seems that there is very low diastolic pressure. There is aortic regurgitation.
Is there any aortic
How AI
regurgitation?
how
Is
much
the
AI
question on the
There's not
floor.
much AI.
What
I
did
think-
you give me?
I think there's some
35?
now there's some ectopy. Our resting diastolic was around 60 at the start of the case.
Yeah, we're
No,
seeing like a
there is
40
no some-
here, but maybe
some
because of the
AI.
ectopy. But
Definitely right.
but I
We're
don't
just
think
being
he
told
saw
that because
any
the
in
catheter's
the
now closed.
in the echo.
In the
No, there was minimal to start. This is all flushed.
I have
Now,
life
in
record
this
with it.
case, remember, patient has a very calcific vessels. So low diastolic pressure may be just a matter of compliance rather than AI.
Okay. So,
So
far,
on
so
the
good.
left groin, we are going up with a guide catheter.
Keep going. Okay.
Yeah, so we want to hear what you're doing about the left main. You've been in there already before, and how you're going to protect the coronaries here, if at
Right.
all.
So you'll see it. We are going up with a
So we do.
guide on the left side.
Exactly. So while Dr. Kinney's working on the right groin and getting the wire across and preparing to do the BAV, I'm taking the guide up, the 6 French VL3 guide from the left groin.
And if you're doing the self-expanding valve, we will have to have a guide liner. So what we will be doing is that we will have the guide after the BAV. First we'll do the BAV, but we will have the guide ready that if patient develop torrential AI, that we will go up with the guide. We have the wire here, we'll wire the left main. We have the Godzilla or the guide liner, whatever you have ready. And we'll tell you why we need that.
Yeah. So what we see
Okay.
here
Give
is
me
a pigtail in the LV, and I see that you're bringing up a guide, Now you're going to exchange
Yeah,
that
but the
for your
guide-
balloon
guide is
aortic
in the
valvuloplasty, but
ascending
before
aorta.
that, you're going to wire the left main. Is that
Done, I
correct,
showed it.
Dr. Kinney?
Yes.
We
You see the guide? It's not engaged, but it is very close.
Yeah.
Yeah.
But first we are doing a BAV.
BAV first.
First, you do the BAV, but
And
you're
I just
ready if
wanted to
anything
show you the
happens.
Pacemaker, temporary pacemaker.
So one thing that you could do is
This
also
temporary-
during BAV to inject contrast to see if you're gonna close the corner.
No.
Yeah. Because we're very concerned about. Watch the wire.
Oh, yeah.
So very concerned about obviously the left main and its relationship to the aortic valve and the calcific leaflets. And these are all of the steps that are taking place now to avoid any kind of an issue or a problem.
You know, Roxana,
Yeah.
we do not many, but sometimes we do this stent protection and the stent delivery. I'm not particularly happy to use these thin struts stents for this purpose. I don't know what the long-term effect may. Sometimes it may be better to place double stents to increase the radial strength and to prevent the stent get compressed by the leaflets pushing on the stent. Yeah, but some, I think to use, I like to use double stents.
Oh, really? Well,
Yeah,
I've not heard that. Eberhard?
Yeah, but there's
There's no data. It's just your own
but
feeling.
what kind of data you want to get?
Yeah, you have your own feeling.
There's no way you can get any data about that.
No, obviously, but
In
so
one
it's a
year-
good point.
In 1 year, in a heavy volume center, you're going to have five,
No, of
4
course.
cases.
Dr. Grube,
these
do
are
you? What do you
anecdotal.
do? Well, how do you protect as they
wanna do a
recross
randomized
this valve?
study?
Well,
Let's
first
just have a discussion.
I think nobody's happy with. I mean, that's the only way we can do at this point to protect it with whatever stent you use. But I don't think it's a good one because if we want to protect the coronaries with a stent that's coming out and you kind of trumpet it, you know, getting back in if there's a problem is really a mess. And so I try to avoid it as much as I can. I would do the same thing here, see where the sinuses are. If the sinuses are good, then you know we don't have to worry about it. And then the balloon valvuloplasty kind of gives you an idea where the leaflet is going up and whether the leaflet's going up and whether the coronaries are in danger. You can wire it, but I'm not sure whether. You know,
Ebert, if you really have to place a stent, what is your strategy? Would you place or would you not do the TAVR? I mean, what
No, I mean, if it's an old patient and we have to do the TAVR, I would of course do it. But I mean, we have to admit it's not a good thing. Now, if an 85-year-old, maybe it's not an issue, but a 75-year-old with something like this, chances that he develops coronary heart disease in that area is real. And then
That's right.
trying to get into this stent that's you know coming out of the left main is really very difficult. if not
Dr.
impossible.
Usia?
So if the patient is a low risk or intermediate risk, this
Yeah.
may be a condition to decide for surgery.
Yeah, it's
Yeah,
true.
Dr. Usia?
Yes.
When I have concern to cross to engage the coronary artery, usually I try to implant the valve a little bit lower. So in the main, I can guarantee that the
Could
open
they
cells
inject?
can be engaged by them. So
Do you inject there
Inject,
now? No, I
inject,
don't think so.
Too late.
No,
no,
we don't do that.
we haven't been.
Yes.
But we've
We're not a fan of that.
push. We place more reliance on really meticulously looking at the CT
Yes.
rather than that balloon system.
You get
It-
some additional information, may not be
I guess they
conclusive.
wanted you to inject to just get a visual estimate of where things
Sure.
are and how things are behaving before you go in with your valve.
No, I don't think it
Right. So
you get additional information with injection.
Yeah, I think it's worth it.
Okay.
I don't disagree.
So valvuloplasty done. Things are looking good. Hemodynamics are very,
consider
very
one reason-
stable.
right.
So
Okay.
why did they do the
If you
valvuloplasty?
yeah.
I don't know.
Done.
Why did you do the
Very calcific,
valvuloplasty
Very calcific valve.
as you're going into the left
Even
main?
you know the Yeah, no, very important. The
not
key
properly
was
prepped.
the
Take it out.
using the AR catheter even was so difficult. Very heavily calcium, right? That one of the reason.
Very
It's,
heavily calcified.
Yeah,
you're
even
right,
that
that's the
AR
key. Now,
catheter was having
clearly-
a hard time going in after she crossed. We saw that.
that's
She,
right.
Yeah, but that's
Really had to-
something, you know, the relatively thin catheters, you cannot really compare with the stiff
With the
delivery
stiff,
catheter.
valve, yeah. Okay, so Dr. Kinney, tell us what you're doing. You're going into the left main with your
I'm engaging the guide with the left main
It's
right now.
ACT, Vicky.
yeah.
ACT
that?
is 320. So our ACT is
Good.
good here.
TE up, please. Right now we don't need TE. And then we have the run through wire will go into the LED. Okay, excellent. No curve here.
Okay.
Give me the lead. Oh, you guys.
Yeah, that's okay. I got it. Just let it bleed.
It's a great case, actually. Really great case.
So we tend to wire after the BAV because we found often, so we engage the left main even after the BAV. We find things often tend to get crisscrossed, and you've got stents down the LAD and it's all crisscrossed. So we do it at this stage, is the wiring. And just to say, I mean, to respond to the question of why we didn't do an injection,
Don't die.
there's several
Right now I'm in
reasons.
the LED.
The
the
foremost
circle.
was with this severe vascular disease, you need to do the dilation with the valve that would be the post-dilation size. So that's a 24 in this patient. The risk of doing a 24 pre is that you create severe AI, which obviously makes things a lot more complicated and you're under pressure and rushed.
Okay,
So
get
we
me
prefer,
the-
there's
Okay,
no
so
point
wire
doing that
down the
injection with the
LED.
balloon we had, which is only a 20.
Yes. So we have wired down the LED and then we have the guide liner here.
Guideliner coming.
Guideliner is going to come now.
Hold the wire. Run through. Run through.
Yeah.
I need some blue towels so people can
And
see.
tell us about the guideliner use for left main protection routine or only in the core valve? Or
Only
what?
in the core valve, not in the sapien. You don't need it. You can leave the wire and the guide comes up. And the reason we'll show you as we are doing the procedure, why you need the protection with the guide liner and not just the guide. So here you park it there. We're not putting a stent, right?
No, put a
Putting
stent.
a stent.
Putting a stent.
Very
Hold on.
fine.
Give me some blue towels so they can see. Okay, no more.
Okay.
Good.
So guideliner
Now we
going
have
in
the
next.
stent, which is what size?
The 3518 stent, because
3518.
it's such a short left main, this stent will probably end up in the LAD. So that's why it's a little smaller.
Yeah.
And you have to, no, but remember if you have to put a stent, you have to bring it out as a tunnel.
Absolutely. That's why it's 18. So it'll go all the way out. The objective of this stent is
So
so that we'll
hopefully
push
you'll
the leaflet out of
magnify
the
this a
way.
little bit, like so where we could see it nicely for
Mag.
the coronary.
Okay, short,
Yeah.
good.
Better.
Done.
Thank you.
So you can see the guideline is just in the ostium of the
Yeah,
LAD.
we see the guideliner
Stent's
very
coming out
nicely.
in a moment. Stent-
Everybody
stent
sees
there.
that.
Stent in the
Stent coming
proximal
in.
LAD.
Doesn't see this.
Okay, now we are going up with the valve. Give us the valve.
Guideliner.
Okay, we'll show it to you why.
I'm
That's a
gonna,
great-
she's
The valve
gonna
has
show
to
you.
be there. You know that if the guide, this valve, since majority of the valve will be the upper,
Let's
above the
see where our
skirt.
pigtail is before we get to community.
Yeah, I think because
lot
we
of
have to take
diamonds
the guide
behind.
out quite a bit into the aorta.
So otherwise you will have the guide behind.
Okay, now you can go back to your usual
valve.
magnification. Everything is waiting,
we'll have
ready
it
to
the
go
high
for
mag.
anything that could go sour, as
Show
you can
this,
see,
is good.
guys.
Show this is good.
Hold the wire, hold the wire.
Just
she's
going to show you
coming
the
in now
iliac.
with
So
the valve.
As predicted, this is a little snug here. You can see this, a push-pull technique. I'm pulling back on the sheath as this is, see, it's not a slam dunk. I'm pulling back on the sheath as I advance this
And
valve up through.
two people have to pay attention here is the first operator and the third one who is holding the wire. They have to be working together.
A
Yeah,
mag
keep
up.
going.
So I
Yes.
think the reason for the
now
guideliner
very
is the
important-
stabilization
Pigtail.
after the valve is placed, Dr. Colombo.
No.
So things are stable in
not
case
that.
things
I'm
go
getting
bad.
the guide liner out. See.
And now you see.
So now the guide is out.
Right.
Okay.
We need the JY for the pigtail. We need to fix the pigtail next. What are we doing?
So everybody's
No,
following.
now Gilbert, we can ask.
There's a little bit of
No, I'll ask Gilbert.
okay.
Okay, now Gilbert, can you make a point that do we need to do something to the valve before releasing which can potential prevent the left main occlusion.
Why they don't put
Well,
cellular
we've
protection?
noticed that actually the head marker, if it's in the outer curve during the time of deployment, one of the common short tabs will be less likely facing the left main. So that's, it obviously is constrained by the spine, but you can see here, we're not at the implant angle yet, but we'll be able to see once we are at the implant angle where that head marker is.
Excellent.
So we'll see that now.
Let me just respond to Dr. Colombo. He's asking why we're not doing cerebral protection and what are we doing here? This is actually this is the pigtail. So we're bringing the pigtail down from the radial so that we can do our root shots. We got spasm.
Yeah.
We need a stiff wire.
No, we can
It's not
see
gonna
you're
work.
trying to bring
Yeah,
the
we can't do cerebral
pigtail
protection.
for the
Not
root
even
shot
that,
before the
I think
delivery
the
of
radial artery has
the
gone into spasm.
valve.
Yeah.
So a critical point here is that we're getting ourselves fully set before we cross the aortic
Now,
valve
why you
here.
need radial? Why don't we just use the
Pigtail.
guide
You
and go?
can't because you got to back it. You have to jail it.
Which one?
The guideline, everything has to be jailed.
We still will be okay.
We can still,
We'll see
the
it.
other
We'll
question
still
is
see
if
it.
you have an access issue, you can inject through the guide.
I think we don't need.
We'll bring it down.
Well, I think you're coming. You got good. There you
I think
go.
we'll see it through the guide.
Here comes.
Last
Very
question we did
nice.
was only with the guide.
No, we do. This is easier.
Your pigtail is making it nicely into the cusp. We're seeing it.
So much calcium in the
Okay, ready?
Calcium
arteries and the
everywhere.
spasm now, yeah. Yep.
That's
Yeah,
a-
one thing we
it's a
didn't
calcific
appreciate,
artery.
when shown a CT scan, there's also a big chunk of calcium in the sinotubular junction. So I think that's something that you'll probably see at the time of deployment when we ready
Okay.
to cross.
Get it. Inject. Test.
So the next is to see the
Fantastic.
cusps.
Go
Your,
high back so they can see everything.
Hi, Mag.
your root shot.
Okay. So the pigtail's in the right cusp, not the non, but we
Yeah.
can make it work.
Okay.
That's okay. Wherever it is, leave it.
It's
Who is
good.
holding the wire?
You're on the guide. Okay, this is going deep.
No, but you want to take a picture first. No?
No.
Okay.
Just going.
So the guide's, we're buckling the
Wire may
guide.
have elbow. 1 second.
That's not a.
The guide
Just
is
your
like
guide's
talking
bucking,
to there you go. Maybe you pull the guide back a little.
We've got past it.
There you go.
And it's messed up. the
Nice.
pigtail. Wait, That's,
Why
what
are
do
you going small?
Okay.
Blow my
There we
Mag
go.
up one. Up
Go.
one.
higher
All right,
man.
we've good. Go to the picture. Quick. 10 hour.
See, you seen
quarter.
that now?
Yeah, we
Pigtail
see
again
everything
has,
very, very
buckled
nicely.
up.
You keep going. We're
No,
watching you.
Pigtail has buckled up, so probably
Yep.
only the guide will help us.
Good.
Okay.
Pigtail's good.
So now what has happened is I've completely,
Test.
the guide is outside.
this.
You see, the guide is totally outside.
Start doing it.
But then our guide liner is in the left main. Okay, I'm going to go cine, 1 minute. Inject.
Why they have the...
You're injecting through the guide right now, right? Or is that the
pigtail.
pigtail?
Come up a little bit. We're gonna come up a little
Pigtail.
bit.
Pigtail.
Coming up a little bit.
It's kind of in a funny
You
cut.
can see the head marker is
We need more dye. Go 15, 15. No, that doesn't work.
so you can see the head
careful.
marker is more like outer curve,
pop up
but
the
fixing
lever.
you slightly.
It's too high. Can do an injection.
Yeah, no, they know it's high. They're
Take a
not
picture.
going. They're
Let's take a
going in
good
a little bit
picture now.
more.
We're
We're not
having a
gonna
hard time to
inject-
put the pigtail
inject.
in the non-coronary
Yeah.
cusp.
Good.
Well, shouldn't
Can
Go
we
in a
inject
little
to the guide and see?
We're good. I've gone in a bit.
Okay,
It's
that's
gone
good.
in.
I think we are zero now.
No,
Okay,
we've gone in. We've gone in.
Open.
start releasing.
You are 6.
Yeah, I know.
Okay, now we are going to start. I'm going to go inject. Inject.
Keen, our hemodynamics are okay. We're not
Yeah.
under pressure from that perspective. Yep.
Inject.
Okay.
Okay, good. Start pacing. Now you see that the valve is beginning to,
Yeah,
so you
we
start
see the
pacing
valve. The
while
valve
we
is
are ready
opening.
to anchor.
Jason, your teeth.
Pacing going on.
Pull back.
We're coming up.
I'm pushing the wire a little bit to pull it up.
Yeah, we're
No,
coming
no,
up.
don't
We're
do
coming up.
anything. Okay, good. We anchored good. Okay, stop.
Stop pacing.
Stop
Puff.
pacing. Inject.
Do you do that?
Inject.
Picture.
that's
Good.
very
I think it's looking good.
That's good.
Yeah,
Perfect.
looks
Okay,
good.
so what I will do is take the pigtail out and we are going to release.
Be careful.
Yep, pigtail out.
Okay, nothing is low. It looks good. Okay,
And
release.
Dr. Colombo, you see the usefulness of that guide liner,
I'm
keeping
doing
the
that.
stent in place. The
Ready?
guide is out.
Yes, yes. See what the guideliner is doing, like Roxana just mentioned,
Yep.
because the guide is out. Now I pulled the guideliner out a little bit. Yes.
Okay, pace at 120, please.
So if you see that, if I need to advance, I
ready?
can advance the guide.
We're at
But
I'm neutral.
guidelines,
Yeah.
yeah, ready.
Yeah, I got it. I got it.
Wire is good.
Perfect.
Okay. The other tab hasn't been released.
Still on.
No, you went in.
Yeah, I know.
Pull back.
Good. Are you gonna?
Yeah.
There,
Released.
tab is off.
Are you
Wire
pacing
back.
or?
Tee up.
Echo up.
Tee
Echo
up,
up.
tee up.
Echo up, Stem.
Good.
Wire back more.
Stop pacing.
Okay, now
Okay.
wire forward.
Hemodynamics are great.
More wire.
Don't lose your wire.
Wait. Yeah, we're good. Good. More wire.
Watch more wire. More wire, more wire.
Good work.
Okay, good. So what I'm going to do now, right now, is inject to check the left main.
Yeah.
Should be
Okay,
pigtail.
hold it, not pigtail.
Very gentle. You're in that LID.
Things look
Yeah.
good.
Nice protection.
Yeah, can I
The
emphasize
sinus
this?
is
This
big
is the
and
classical
there's
case.
no
The
issue to
sinus
worry.
is
Why don't we
so
do a
huge.
root shot?
Yeah.
with this?
So what you
Yep.
do is the stent. You
Take that out.
So now
But
you can.
just making a point, what was the need for the guideliner versus the guide? If you see there,
Yeah, no,
the
we
guide
saw
would
that.
have been
Very nice.
behind.
Beautiful point. That was
Yeah,
really
so, but
good.
if-
But now you don't need any of this, right? So you can come out completely, or
No, we're just making a point. They want to do a picture with the. Remember, I did a selective injection into the left main. They want to do a non-selective injection with the pigtail in the valve to make sure the left main is still open. Of course, if things would have gone wrong, we would have seen massive ST elevation with the low blood
course.
pressure. But right now, blood pressure, hemodynamics, everything is good.
Although it's strutted open at the moment.
We are going to do the aortogram to show the
Mag
valve
out.
position.
Mag out. We can't even see the pigtail. Oh, there. Okay.
I don't think they needed that anyway.
Now, careful when you're getting into the valve. Yes, get into the. Wait.
there's so much
Okay, good.
radial
We'll go
calcification.
inside.
I mean, in
That's
the
perfect. That's perfect.
subclavian.
That's perfect. That's
You're
perfect.
having a harder time with that.
Good.
Yeah,
Yeah. I'm pushing a lot. That's good enough. That's good.
that's a good place, no?
15. 15 injection.
What did the echo say?
We're gonna hear about the echo, but it looks like they just want to quickly make sure that the
1
left
minute, 1
main is
minute.
okay.
Let's do everything here.
Once they know
Around
that,
the
then they're gonna
severe
go
AI.
to the TEE will come in.
Okay, ready?
This is okay.
Good. Do you want to back?
Okay, ready
the,
for
you wanna-
injection?
Do you want to back the guideliner just into the root? Let's back the guideliner into the root. Perfect.
Good. Okay.
Pick this a little lower, Jason.
That's okay.
That's okay, we want it. Inject. Beautiful positioning.
Yeah.
Good.
Yeah, so we'd like to
Okay,
just
well,
see
now
how much AR there is because you still have a valve across, but
Echo.
we see the ventricle.
Yep.
So maybe the echo will help us, but this looks good as far as the left main goes.
See the native leaflet you can see
The eye is
behind,
a little
like
bit
a nice.
more
line.
than what we accept in 2018. Yeah?
Mild.
Still
There's
used to
some
die.
mild.
Okay,
Mild,
maybe Stam, you're gonna tell us what's going on with that AR we're seeing?
Yes.
Show that.
As you can see, there is mild posterior
If you
aortic
see
regurgitation.
An angio, I don't care to look at it.
Because angiographically it looks a little bit more, but maybe by echo you could tell us better.
Yeah, let me see.
24, right?
Yeah, 24.
24.
Because some
Let's
kind
take this out.
Excuse.
Fluoro.
Whatever is worse.
Jason,
these
yeah.
don't
So you're right. In this 2018, we will not leave this kind of
No much.
regurgitation.
No much.
Fluoro.
In the past, we were leaving it, but we definitely would not leave this kind of regurgitation.
It's coming out
Yeah,
smooth.
So as you can see, it's
Tight. You're not
mild,
overcaptured, are you?
mild at most.
You overcaptured?
What balloon size?
Yeah.
What
Did we lose
balloon
the wire?
size?
Oh, wire. Probably we lost it.
24.
No, there, it's there. Line's there.
Okay, this is there.
It's at 24 because the mean
Just
was
push the-
24.2.
24 Z med or
Just a Z.
Okay.
See, even pulling it out difficult.
Yeah, it was jumping around in the
Wire, I'm finishing the wire.
We got
now.
it. We got
But
it.
I guess you still leave that wire down the LAD for the post still as well, right? I mean,
No,
you
we
did,
took it out.
You
Guide
took
and,
everything
wire,
out?
Everything is out.
No.
but would you have left
Everything
it?
Yep.
The decision is made
There
immediately.
should be no problem.
I think we
Now
already-
no problem
we
on
already
this.
evaluated
I think
the-
it
the
looks more
sinus is
ominous to
large
leave it,
enough.
but it's not ominous.
Yeah, so that
Yeah.
sinus looked large
key is-
enough and there was no
Yeah.
concern, and now you're going with a 24 balloon.
to
Is
the
that
view.
correct?
That is
Yes.
correct. 24,
24
CMAD.
Z.
And the key was the very important, and this is what the literature is all about. Once you have the large annulus, sinus or valsalva, that even if its
T up.
left main height is low,
T up with post dilating.
How much is the AI? Anything?
What's
Yeah.
the
Mild,
pigmentation?
mild.
Yeah.
Mild AI. According
I'll
to
bring it up.
STAM, mild AI.
Let me just bring the
Some
pigtail up. Let me just bring the pigtail up.
Yeah, but by
Wait,
the
wait, wait.
by the angio, it just looked a little bit higher than that.
yeah,
I
it's
think
there.
so.
No, no, it's
I'm
there. Yeah.
But
Go.
we had the
Ready to
wire
pace.
across, so we cannot go
180.
with that.
yeah,
You
that's
ready?
true.
Ready?
Pacemaker.
180 pacer. Hold the wire.
Yep. Yeah.
Okay, now just make sure blood
Coming up
pressure
a
is
little.
good. No.
Is the balloon too low?
Going up. Yeah,
Yeah,
Yeah, good.
you brought it back.
Now, good.
missed it a bit.
That's it, not more.
Very nice.
Okay. Continue pacing. Here is very important till it completely deflates. Pull the balloon out. Stop pacer.
Okay.
Okay, Stam, have a look.
Yeah, look.
Take this out. Take this out. Pigtail.
Pigtail.
You want hemodynamics?
Yeah.
Okay.
It's gone away.
Gone away.
Gone away.
Show the echo on the live.
Can you show us the
Echo.
echo? And then are you going to do a
Yes.
yeah, there we are.
Hemo.
I don't think I see. We're very minimal, if anything, right? I'm not an echocardiographer, but
3 Alifeni. 3 Alifeni.
2 RBCs.
So what? Yeah. Yeah. So what we are going to do now,
5 RBCs
the
going across.
hemodynamics, then pull back the pigtail into the aorta, and then do the final aortogram.
Sounds like a
So as
good
Roxana,
plan.
you asked us earlier. Yeah.
We really would like to, even though you're very far along, we really would like to see the access at the end and what you do with that collapsible sheath, etc.
Sure. We can do that.
You have to flush it. This one you flush.
This one is flushed. Yeah, this one's flushed.
Whole round will be closing.
This was
When
a
I- when I
great
wait.
case.
There we go.
All right. Show the hemodynamics now.
It's done. It's flushed.
Absolutely no gradient.
Okay. Pull the guide out.
Yeah.
Balloon
Because
out.
zero-
And air index is 0.35 and
She
so
wants to do pigtail
0.4
off.
almost, and now we
Right,
pulled
you
it
have to
out.
swat-
Let's do the last aortogram
Wait.
because I know we are getting a little late for our lectures, but I think this was a very important case, step by step, beautiful demonstration of a difficult
Okay,
vascular
No, this is a
access
fantastic
without cut down.
case.
Probe up.
Probe up.
One more mag. Or just...
No, that's good, Mag.
Oh, I think you have to just take it here. Okay,
There.
good.
Up a little higher.
Ready?
It'll cause AI.
Inject.
Wow.
Perfect.
Very
Not even a
nice.
single RBC.
You're very happy. Yeah, very, very nice. Beautiful.
Good.
Let me show the implant.
This is really a very, very instructive case. So,
Take it out.
Jason, tell us what's your plan about the sheath quickly, because we would like to go to the lectures.
Yeah. Sure. And it does take 5-10 minutes to get set up to do this properly. We'll be pulling the sheath that had the 6 French sheath that had the left main protection in. We'll come back there. Only bifurcation. We'll be taking DSA shots. We'll exchange out now for a very stiff wire. We'll have aortic occlusion balloons in the room, not open in case we have perforated. And then we'll just carefully deflate, remove that sheath. It comes out at about an 8 French size. Do a quick DSA to make sure we've had no perforation. And then if it looks good, often actually after this sheath, it looks very good because this sort of tacks up any flaps and things. Then we just deploy the per-close sutures and we're done.
So if
Okay,
you would
so last
film
word I
that,
want
I
to-
would
Gilbert,
appreciate
no,
that
no,
if you
no,
would
Gilbert.
record that
Surely
for
that's
us
the
so
guy.
that we
Sure.
could come back to you
Happily.
and watch that and take us
Happily.
through that the next
Gilbert,
time
you
we
want to
come
make a
live.
point? Yeah. No. Okay, Gilbert is going to make the point of the commissioner
Excellent.
tab against the left
So,
main.
so the final thing we do now is to go back to the initial aortogram view and look at where the C-tab is, because that's a very important thing in terms of coronary access. So the C-tab represents one of the commissural poles, and you can basically see roughly where it is and try to map out where the other two commissures are for coronary access.
Excellent.
Okay. All right, you ready for the lecture? Yes.
Wonderful. Thank you so much for this fantastic live case. Thank you.
Roxana,